This is Dr. Farnan.
And Dr. Lanier.
Yes. Can't forget Dr. Lanier from Cutting Edge Foot and Ankle here in Nashville. And you're listening to another wonderful episode of MedNation Podcast, the show that involves two podiatrists having conversations with the leading industry experts for people who love to learn about everything head to toe.
Today, we are going to discuss inpatient versus outpatient, comparing two types of patient care in podiatry. Before we start, Dr. Johnson, could you tell us about yourself?
Yes, right now I'm a clinical assistant professor appointment at the University of Michigan Medical School, but I'm acting as a podiatrist and wound care specialist for the hospital system arm of it. So I started this role in July of 2021. Going back, I did a 2-year fellowship at the University of Pennsylvania as a clinical research and wound care podiatric medicine fellow and surgery fellow at that hospital system. And then before that, I did a 3-year surgical residency at Aventura Hospital in Miami, Florida. And then I trained with Dr. Lanier. I went to the same school as Dr. Lanier at OCPM. I think you were a class of, 2015?
Yeah.
So I went to, Kent, at that time it was OCPM, but now it's Kent State College of Podiatric Medicine. I was class of 2016. So that's where we kind of linked up around that time. Yeah, so I mean, I do a lot. I do have my own company as well, luckily, where I do education and consulting, both educating industry leaders, our industry personnel, or people that want more consulting and understand how to get their startup products launched into getting purchased by larger companies, and also teaching residents, students, pre health students, fellows, and even doing some career coaching now, trying to help some of the individuals that I know that want to get into academia. So I'm an academic podiatrist. It has its pros and its cons. It's fun. It's fun though.
Yeah, it seems like you're a jack of all trades, Dr. Johnson. That's pretty impressive.
I just want to mention that we have two Kent State alumni here. We both have accomplished a lot. If the admission office is listening, they did a great job. And Dr. Farnan.
Shout out to Shoal College, the best of the best.
Hey, we're all in the Midwest, so we all know how to handle winters and stuff. So that's fair enough.
Yeah. So, and I know, Dr. Johnson, you were talking about, you really have a passion for research. Talk to me about that.
Yeah. So I started off as like I said, I did a 2-year fellowship in research, and
right.
So when I came to the University of Michigan, research is one of the things they want me to do. So right now I'm doing the research itself. I mean, it started when I was an undergrad, to go all the way back to when I was at Barry University, which happens to have a podiatry school too. When I went to Miami, Florida, I was an undergraduate researcher where I got the opportunity to do both basic science and clinical research. I did basic science research year round. Actually maintained and managed an aquarium, like a $500,000 aquarium, where we did endocrinology studies on fish, basically looking at different cycles and trying to understand hormones and everything. And also little pollution studies as well, because if you look in America, we have more female individuals compared to male, assigned birth individuals. And most of this is attributed to the amount of plastics that's eluted into the water and stuff like that. So got to do some research on that stuff, which is interesting. If you look, certain populations in Florida there's towns where it's like 9 out of 10 babies are female babies, and it's because of what's going on with the plastics there. So interesting pollution side there, but I won't go on that tangent. But that's sort of interluded into how I got interested in a research kick. So yeah, right now I'm doing a lot of clinical research stuff. I mean, basically incorporated into my practice. It's not like a lot of RCT where we have one faculty in our facility or in our department. He's basically 90% research. I wouldn't say I'm 90%. I'm probably like less than 10% research. A lot of nights and weekends because I'm junior faculty. Right now I'm applying for grants because you got to have grants in order to have protected time to do research in academia, which is we can get into later.
And you said you're at the University of Michigan right now, correct?
Yeah, I'm at the University of Michigan, correct.
I have a friend there who's actually a good close friend, Colin. Do you know Dr. Brian Schmidt?
Yeah, Dr. Schmidt. So that's what I was referencing. So yeah, Dr. Schmidt. Yeah. He's one
of my closest friends and confidants. Him and I, we were, he was at the time the number one student in our class, and him and I started to become, we're brothers technically almost.
Okay, good. Yeah. So that's what I was referencing when I said, so he's the clinical scientist where he has large grants, and he's been doing it obviously a little bit longer than me, going on, I think he's at year 10, or at least 10 years from residency at least, right? Or 10 years after graduating. And,
right.
So
So, Dr. Johnson, quick question to you. So, neither Dr. Lanier or myself have done a fellowship after residency because we just didn't want to, I guess, do any more schooling. And at the time, fellowships were so new. Talk to us. What made you decide on doing a fellowship?
Yeah, that's good. That's a good. Yeah, so I got right around the time where fellowships now it's kind of like the end thing. I mean, initially, yeah, if you would have told me when I was an intern that I would be doing a fellowship, I probably would have laughed because I was like, oh, I just want to go straight and make my salary. But the thing was, for me at least, it's a person. I think fellowship is a personal decision. You kind of have to figure out where you want a career trajectory, your career, which is tough because you don't know what the economy is going to be like. You don't know who's going to be president, as in what policies they're going to implement. So it's a lot who your congressman or congresswoman will be in certain states on how it works. So you have to think about how you want to practice as a physician, then of course as a podiatrist specialty. So that was the thing. So when I was in residency, I was doing a lot of trauma cases and all of that, and it was fun and it was great. But then I started finding out more about how billing works for trauma and how long it's taken to get reimbursed. And I was like, how long, spending X amount of time away from the family because I have 2 kids and a wife. And it's like, you start to figure out what you really want to do. And I was like, I love limb salvage. I love my limb salvage cases. So I spent hours and hours with the plastic surgeon that did a lot of lower extremity recons and asking him how he understood, basically how he understood it. Soft tissue recons, because I like soft tissue, not necessarily bony, osseous stuff, but soft tissue and plasties and orthoplasty type stuff. And eventually, I was like, you know what, I want to take this a little bit to the next step and try to understand it. Basically start looking at fellowships around the nation. And then I wanted to narrow that, I want to be at a place that has a large academic institution so I could understand the politics on how to navigate it and how to become first off as like a clinical assistant professor, how to move up to a full professor, those type of things. And so I knew I wanted to go to a fellowship that had that camaraderie and understand it. And that's where it was. So eventually I interviewed for a couple of fellowships and ended up choosing University of Pennsylvania.
So let's navigate through the inpatient and outpatient patient settings that you are seeing patients in right now. Do you have any preferences? What are the differences you have experienced in both settings?
So technically I do both inpatient and outpatient. The way we do it here at Michigan is, we'll keep it as if our faculty didn't float. Now we have faculty that we expanded out to the VA, the local VA. So our rotations have changed, but essentially we have 8 podiatric surgeons, podiatrists, and we rotate every 8 weeks call, but now that's going down to 5. But essentially, let's say it's 8 of us and we all rotate the call. And essentially when you're on call, you're a patient in-house podiatrist, podiatric surgeon for that week for 7 days from Monday to Monday, or Monday to Sunday. You sign out on Sunday night. And the next provider will take over on Monday. But at that time, you have no clinical obligations. You'll have only clinical obligation you have is fellows clinic, where the attending for fellows clinic 3 times for 3 half days out of the week. But the fellows patients, and you help them make the decisions on how to manage it. And after that, you go and do your surgeries and go see your inpatient patients and do the rounding. And then when I'm not on call, I have an outpatient side where I'm in. So like I said, I do wound care. So I'm in podiatry clinic 3 times a week, not including admit time. Basically, I get a day off. So if it's Wednesday half day and a Thursday half day, and then after that, I'm in wound care the other days for half days. Hopefully, it's not too confusing. But so that's my outpatient setting on that side. But essentially, so I still see on the outpatient setting, I see anywhere between 20 to 23 patients, depending on a day and what's going on. And then the only thing is on outpatient, I already kind of can know what I'm going to go get into. But when I'm on call or inpatient, you never know what's going to happen, because that day you can't plan out your day. You don't know if you're going to what time you're going to have dinner with the kids. Most times you can, because kind of like say, I'll rather do this case the next day or something. But you never know, especially if we don't have residents. So the fellows they're protected and have their fellows wellness. So if they're out that week and you're on call that week, you're the only foot and ankle expert in there that can do this stuff. And we have foot and ankle ortho, but foot and ankle ortho is there for like ankle fractures and stuff. Nothing. Right. They don't want a diabetic infected foot unless it's emergent and I can't get there quick enough or something like that. So if you have specific questions, I can answer. But essentially, you don't know what you're gonna get, and when you're in there, you're in there. I mean, I remember the first couple of weeks I didn't have a fellow. And I was like in there, and I didn't even know the hospital. It's 4 hospitals on our campus. So I'm over here trying to find the patients, and I get in, didn't leave until 10 o'clock, 11 o'clock that night. And it's like, you got to go right back in. Luckily, we have a rule where the consults have to be in by noon. And if it's not in by noon, it can technically go on to the next day. So as long as they get it in before noon, I have to see it within the 24-hour period, which helps.
It seems like, Dr. Johnson, that you do a lot. Do you ever feel burnt out? And if so, how do you recover from your burnout?
So that's why I try to make, so luckily, like for now, like I have a PT, I make sure that I have my scheduled PTO week. So right now, today's my last day on. So I'll be off for the entire week of next week. And then I'll go back on call. Right now I'm on outpatient, but then I'll be off for a PTO week, and then I'll go inpatient when I get back. So I make sure that, I utilize those PTO days to try not to burn out. But you're right, like when you're in the middle of heat of battle throughout those weeks or transitioning, you make sure, you have those scheduled times. Like luckily, like I remember, I'm at in a college town. So I either go to a sporting event because there's always a sporting event going on, try to go to concerts now that COVID's gone and they have more outdoor venues, things like that, and spending time with the kids. Like I said, I teach new tennis and things like that. So you try to have scheduled times where you're going to do X, Y, Z. Otherwise, you won't ever do it, right? Or if you don't, like if you want to be, you want to be healthy and work out, make sure you still have your schedule where you're working out. And that's the biggest thing, because remember, this is like I'm transitioning from a person that's always been a resident and fellow to now I'm an attending. So this is my life. You guys already got a couple of years of doing it, but it's like, this is my life. If I don't figure it out now, I never will become good at managing this burnout, because there's always stuff. Like I said, then I have other businesses and entities that I'm running and meetings. And a lot of people that I work with are either in the UK or in the West Coast. So it's trying to figure out sleep cycles and all of this stuff like that. But it helps when the kids are asleep or if everyone's asleep. But I'm up ready and alert for my patients the next morning. So it's interesting.
I wanted your input a little bit more on the hospital versus private clinic. Yeah. Obviously, you're working in both settings right now. What is this downfall or the pros and cons of each, working in the hospital setting and working in private setting?
That's a good question. So yeah, that's actually great, because I didn't even think of it when I had signed up for it. But it's little things like follow-up. It's like you want to be able to follow up. Let's say you wanted to follow up with the patient the next week, and I'm at the hospital the next week, and I can't really get them in, especially if the fellows. Sometimes I could try to squeeze them in on like the fellow schedule, but if it's packed and the university has the policy, so the policy is the policy. You can't really double book that easily or something like that, or especially for a fellow, because the way it's just protected with burnout, which is fair. And it's things like that you don't think about. And then, of course, you got to flip that mindset. This is like when I'm in my inpatient mode, ready to grind. And then when I'm, go back to outpatient, I got to remember, I can't spend as long in the room talking to these patients or talking to their family members, because I got 12 other patients that's waiting. Yeah. So it's like a different whole atmosphere, right? Because it's like, you're not, you're in the hospital, you can just talk and explain, pull up imaging and talk. Not to say you don't do that in your office, but it's a little bit, it's a different mindset, because otherwise your entire day is ruined and your support staff is not happy with you, because, Dr. Johnson's taking 45 minutes with one patient when I can do that out in the hospital, because the hospital, there's no time, unless you need to be at a case or something. Then, of course, on the inpatient, inpatient hospital side, where I do elective cases too, but like when you're in the inpatient hospital side, you never know when the cases are going to be, right? So it's like, that's another downfall, because you can't really schedule it like how you would elective cases, where they're accountable for, if it's a 2 p.m. case, it should be a 2 p.m. case, or they got to figure out how to get a crew in to cover it. But for on-call cases, it's whatever time it goes. Like I said, it's at 2 p.m., but it could be at 6 p.m. And it happens to me often. It just depends on what's going on with the hospital at the time. So things like that I would definitely say, think about it. When you're a student, yes, I want to be like this and be like that, or wear this and wear that. But you got to kind of figure out how you want to live. There's work to feel whatever lifestyle you want, but when you're going to actually be, have time to be yourself and do your,
Absolutely. Well, thank you for taking your time. You are an inspiration for us, and I and Dr. Conner admire your work ethic, and would love to talk to you more in future episodes.
Yeah, definitely. We should probably do it in a year from now. See how it'll probably be a totally different perspective, right? I may have a whole different philosophy.
Right. Yeah.
Of how it is. Right. It'd be great to compare it, and Yeah, I commend you guys, and like I said, I'm glad you guys doing your private practice, because private practice is what keeps things going. I refer out for certain cases and everything to my colleagues, and because like I said, Dr. Lanier and I went to school out here in Ohio, Michigan area, so I have a couple of even some of your I've sent over some referrals to some of your classmates too, Dr.
I bet you do. I wish you lived here. I wish you lived here.
Yeah. So I send it over because I want them, I want what's best for that person at the time, and
Absolutely.
because we have our own hurdles. I just, it depends. Sometimes, especially for new patients, our new patient waiting list, I just not heard now it's over like at 9 months right now. So things like that. Why wouldn't I send them out to a private doctor?
Dr. Lanier and I always try to end podcast episodes with, do you have an inspirational quote or mantra you live by that you want to share with us and the subscribers and the audience that can shed some light? I mean, you're already a very impressive person. So I'm sure a lot of folks look up and aspire to do what you do and what Dr. Lanier and I do. And so wise words do you live by that you could share with our subscriber audience?
So definitely I've always lived by the motto of trust the process. So I just trust the process. Like I have other accolades and things that I want to achieve. And like right now, my next big hurdle is trying to so I'm a clinical assistant professor, and now I want to be an associate professor. And it requires X amount of talks. It requires X amount of publications and, so things like, scholarly activities and notorieties that you have to get before you can even submit your application for that next promotion. And it's not a promotion just based on the, obviously, everyone likes the financial and the pay for it, but it's just the achievement scale that you need to kind of have that leverage in academia that most people aren't aware of. So, but it's like those are, but it's like I can't, stress about it. And so I just trust the process, and I do what I can for my patients, for my research, for my clinical presence, and for my we call them trainees. So for the students, the residents, or the fellows that I train. So, and I always tell them to trust the process and don't try to rush to hurry up and be like me, and don't try to emulate my crazy, lifestyle. Cause you have to kind of balance it. And it took me a while to learn how to balance it. I used to be a yes man. I said yes to everything. Now I'm starting to say no to a lot of things and everything. So it's like, it depends on where you're at in your steps and where you want to be and who you want to be and how you want to define your legacy. No matter what type of physician you are, and like how you want to be defined. But that's the main things I would say is trust the process. I trusted. It's not always rainbows and butterflies. I've had a lot of hurdles. I hear a lot of no's. Just heard a no for from university for something that I wanted. Things like that is just, but it doesn't matter. Like I still go back and try to do this best and keep things going and try to do the best I can for my patients, for my profession, for my family.
All right, everybody. So again, thank you, Dr. Johnson. Thanks, everybody, for listening to another wonderful episode of the Med Nation podcast with your host, of course, Dr. David Farnan and
Dr. Jerusalem Lanier.
We hope you enjoyed our conversation with Dr. Johnson. If you want to hear more conversations like this, as well as join in on our next episode, as always, you can head over to the Apple Podcast and Spotify to hear more episodes like this. If you have any questions for Dr. Johnson and us, check out the links in the description and feel free to email us and connect. Thanks for this episode, and see you guys all next week for another wonderful episode.
See you next time.
See you next time.